Anemia in pregnancy. Anemia in pregnancy is defined as a hemoglobin levels below lesser than 11 gdl in the first and the third trimester, lesser than 10.5 gram per dl in the second trimester. Most common medical disorder in pregnancy. Iron deficiency anemia is the most common cause. Nutritional deficiency, most common iron deficiency anemia. Increased iron demand, 1000 mg needed in the pregnancy. Poor dietary intake, inadequate iron stores. Essential for the RBC production, deficiency common in the malnutrition. Vitamin B12 deficiency anemia seen in the vegetarians, malabsorption condition. Pernicious anemia. Hemolytic anemia, sickle cell disease, inherited hemoglobinopathy causing the chronic hemolysis. Thalassemia, defective hemoglobin synthesis, common in the Mediterranean and the Asian population. Anemia due to the chronic disease, chronic infection like tuberculosis, HIV, chronic kidney disease, CPO deficiency. Classification based on the severity: mild HB, moderate HB 7 to 9.9, severe HB lesser than 7, very severe lesser than 4. Clinical features like general symptom: fatigue, weakness, dizziness, pallor, conjunctival, palmar, dyspnea on exertion, palpitations and tachycardia. Severe anemic features like pica, craving for the non-nutritive substances like clay ice, glossitis, angular cheilitis, iron and the folate deficiency, spoon-shaped nails, cholangia in the IDA. Fetal effects: intrauterine growth restrictions like preterm birth, low birth weight, increased risk of the perinatal mortality. Diagnosis: complete blood count. For the low hemoglobin, low hematocrit, microcytic hyperchromic RBCs in India. Serum ferritin, best indicator of IDA, low in IDA, normal or high in the anemia of the chronic disease. Peripheral blood smear, microcytic hyperchromic RBC in IDA. Megaloblastic changes in the folate, B12 deficiency. Serum iron studies. Low serum iron, high TBC, low ferritin, IDA. Low serum, low TBC, normal or the high ferritin, anemia of the chronic disease. Reticulocyte count, low in the mutational anemia, high in the hemolytic anemia. Hemoglobin electrophoresis to diagnose the thalassemia or the sickle cell disease. For the management: iron deficiency anemia, dietary modifications, increase iron rich foods, meat, green leafy vegetables, legumes. Oral iron therapy, elemental iron, 100 to 200 mg per day, ferrous sulfate, fumarate, gluconate. Take with vitamin C, enhances the absorption. Avoid with calcium, tea, coffee, inhibit the absorption. Parenteral iron, IV iron therapy, indicated if severe anemia, malabsorption, or poor compliance with oral iron. Iron sucrose or the ferric carboxymaltose preferred. Folate deficiency anemia, folic acid 400 mcg per day. It's a high risk like previous neural tube defect. Vitamin B12 deficiency, iron B12 injection is severe deficiency. Blood transfusion, rapid RBC transfusion in the life-threatening cases. Prevention of anemia in the pregnancy: protein iron supplementation 60 mg elemental iron plus 40 mcg folic acid daily. Early screening for the anemia: first antenatal visit, repeat at the 28 weeks. Adequate nutrition with iron, folate and the B12 rich foods. Anemia in the pregnancy: HB lesser than 11 g first and the third trimester, lesser than 10.5 in the second trimester. Iron deficiency anemia is the most common type. Microcytic hyperchromic RBC and the low ferritin confirms the IDA. Oral iron therapy is the first line treatment. IV iron is used in severe cases for the poor absorption. Folic acid 400 mcg per day prevents the neural tube defects. HB lesser than 60 with symptoms requires the blood transfusion. Protein iron supplementation prevents anemia in pregnancy.